Pod is powered by Parkinson's UK, the charity that's here to support every Parkinson's journey every step of the way. Wherever you're from, whatever you need, visit parkinsons.org.uk for more information.
Hello, gorgeous people. Welcome to the latest thrilling edition of Two Parkinson a Pod, the podcast for people with Parkinson's by people with Parkinson's. I'm Dave. He's Kieran. Together we've had the dreaded Logie for 28 years. Kieran, I'm on my travels today. I'm in Robin Hood's Bay on the Yorkshire coast. I'm loving it.
That's why you're looking especially gorgeous this morning, Dave.
Thank you. I've been walking on the cliffs looking for puffins.
Looking for what?
Puffins. The bird.
Go on, explain what puffins are for the layperson.
A puffin's like a little, it's like a sort of, it looks like a penguin.
A mini penguin.
Yeah, it looks like you, Kieran. It's a bird that looks like
Fair
you.
Fair enough.
Apparently this time of year they start coming ashore. And Benton Cliffs is where I went, which is a Royal Society for Protection of Birds sanctuary. Amazing place. It's like Jurassic Park. Incredible drop-offs and loads of gannets flying around.
Puffins were only in sort of the Atlantic area, no?
These are Yorkshire puffins we're looking for, but we didn't find any, sadly. But
what's the difference? Are they just a bit tighter?
They drink bitter.
They drink bitter. I'm just kidding.
Is it how much? How much?
Go on, do an impression of a puffin.
Yeah.
Do an impression of a puffin. Go on.
No.
I'll superimpose an image. But did you find some in the end then?
No, we didn't. We didn't find any, sadly. But we're going on a puffin adventure on Tuesday as well, so hopefully we'll find a puffin then.
I didn't know this was a thing.
Yes, it's massive. I found a dead one on the beach a while ago. That's the nearest I've got to a puffin so far. But, you know, my wife's lifetime ambition to see a puffin, so I've got to fulfill that for her. But just very nice. It's where we used to come on holiday, Robin Hood's Bay, where I am. Really gorgeous part of the world. Just get away from Parkinson's a bit and just chill out for a few days. It's lovely.
It's childhood holiday destination for you, right?
Exactly. But you've been on your travels as well, haven't you?
I have, yes. Spain, south of Spain. I took a plane, Dave. Can you believe it?
A plane to Spain in the rain?
A plane to Spain. A little bit of rain, actually, but a little bit of sun as well. So, and a lot warmer than here. So
that's the first time you've travelled since DBS, isn't it? How did you go on getting through airport security, all that sort of stuff? Makes me a bit nervous thinking about it.
Well, I was a bit nervous, but we went prepared. I did take my letter from the hospital to show that I've got implants to evidence it. The guys at the airport were really good, both here and in Spain. And I didn't go through the scanner because that's the thing you can't do when you've got implants like I have in my body. Instead of going through one of those scanners, they just gave me a rather intimate pat down.
That was the best bit of the trip.
Well, yeah, that was the highlight, yeah.
Highlights of a week away, but good pat down at the airport, yeah.
Yeah. But, you know, it was fairly seamless, to be honest with you. Wore my sunflower badge, skipped all the queues. Didn't even ask. They just pick you out of the queue and give you special treatment. Flight was amazing. I didn't think I'd take a plane again, Dave. Last holiday was 3 or 4 years ago when I took a flight, and I was so scared of getting dyskinesia and the whole anxiety-induced dyskinesia on a plane, and you know the whole anxiety and disco thing mixed together. One sets off the other, basically. And went back to the same resort that I've been to before, which you've been to as well.
That helps, doesn't it? Yeah.
Familiarity
is a good thing when you got. I don't know what it is about Parkinson's, but you like to know what you're going to, and you know you want to know everything
exactly.
about
So
the
went
place.
to our favourite restaurant, went to the favourite pool, went swimming. I'd read a few things online about swimming with DBS.
You can swim with DBS, though, can't you?
Yeah, I can. It was fine, absolutely fine.
You put your head underwater, everything, no problem.
Everything, It was fine. I could walk on the beach properly as well, because I don't know what it is about walking on the beach, but for parkies, but never used to be able to wear flip-flops, so I could do that now. And I don't know how to explain this, but I guess some of our listeners might recognise some of these weird little quirks of Parkinson's about walking in sand, but that was a lot easier. And it was just nice. It was a nice break as well. I've been quite busy. Helen's been really busy, so it was a good break. First break for us for a few years, and it's kind of just renewed my confidence in travelling again. So maybe we're going to take a bigger trip later in the year if we can. So yeah, all good.
That sounds fantastic. You didn't feel sort of on a limb because you're away from the specialists and stuff because your DBS, if anything went wrong with it?
No, because they've got, if worse comes to worse, right, they've got like centres there that can care for you there with the same equipment. So the same
Okay.
equipment I've got Medtronic is just worldwide. They're in so many different countries. Every main hospital in main countries would be able to sort of tinker with you if you had to. So it's like an international warranty, put it that way.
Perfect.
So I didn't worry so much about that. Nothing went wrong. I took my controllers with me just in case, but yeah, it's all good.
Well done for doing it. It
thanks.
takes a bit of courage to do that, doesn't it? Yeah.
It does, yeah. And now I've got the bug for it again because I used to love travelling, so I'll do a bit more.
Looking very well at it. Looking very well at it, Kieran.
Thank you.
Should we talk about today's pod?
Yes, please.
It's called What Type of Parkinson's Do I Have? Whenever you chat about Parkinson's, they always say, everyone's different. And we've got Professor Alistair Noyce on, who's an incredible guy. He's received loads of money from Parkinson's UK to fund his amazing research at Queen Mary's Hospital. He's a clinician, he's a researcher, he's an all-round top guy, one of the most knowledgeable men in the Parky world. Let's hear from him now. Professor Alistair Noyce, welcome to Two Parkies in a Pod.
Hi Dave, hi Kuhan, nice to meet you.
Just tell us about your journey and how you ended up where you are in career-wise and stuff.
Sure. So I guess my journey with Parkinson's has been 22 years. I started getting interested in Parkinson's when I was still a medical student at Queen Mary University of London and parts of the London School of Medicine and Dentistry. And I did a summer project looking at smell loss in Parkinson's using scratch and sniff smell tests. And then when I finished medical school, I did what's called the integrated academic training program. So I got a bit of time most years of my post-medical school training to do some research. And during those early years, set up the idea for a project called Predict PD. I was interested in how smell loss and other factors could help us predict Parkinson's in the future. Did some other projects and then ultimately went on to do a PhD with Andrew Lees and Annette Schrag at UCL. Again, focused on this very early or prodromal stage of Parkinson's. And then when I finished that, I finished off my neurology training, but I moved back to Barts and the Royal London Hospital, where I finished my registrar training and then started to set up a new group at QMUL. So I left UCL, and the unit was called Preventive Neurology. We were interested in the idea of early detection and prevention of Parkinson's, dementia and MS. And actually this unit's done really, really well. And now it's grown into a centre. I was the first person appointed to the unit. Now we have a centre with more than 70 employees working across these diseases, which is great. And then I finished my neurology training in 2020, became a consultant at the Royal London. And then, the last 6 years has really been kind of growing our service at Barts Health and the Royal London, which I think we'll come back to. It's in a really interesting part of London and in the UK, and also growing our work at the Centre of Preventive Neurology on early detection of Parkinson's and risk factors, genetic, environmental, and things like that. So that's how I ended up where I am now.
And am I right in thinking you're also an epidemiologist?
That's right. So,
You're the Sherlock Holmes of Parkinson's. That's how I kind of always, you're looking for clues and patterns, right?
Looking for clues and patterns, and those, and so epidemiology is pretty broad. So it really covers the causes and determinants of the disease. But, within that, we're interested in whether the burden of Parkinson's is changing, whether case numbers are increasing around the world. And if they are, what are the likely causes? Are they environmental? Are they genetic? Are they that better education and awareness in certain parts of the world has improved over time and therefore more people are being diagnosed? And then if we believe that the burden is growing and we know what some of the determinants are, what can we do to reduce that burden? So that's epidemiology.
What are the biggest risk factors you found, incidentally?
Many of them you will know about already, and I suspect you've discussed them on the podcast, but there's this association with pesticide exposures, there's associations with heavy metal exposures and potentially with volatile solvents like TCE, trichloroethylene. And then there are associations with type 2 diabetes in particular, potentially with air pollution, some viral or other infectious diseases, and then these very interesting, apparently protective associations for things like smoking, physical activity, caffeine, and things like that. So it's really kind of studying all of those things and trying to work out which ones we really believe and which ones we don't believe.
Do you have a personal connection, if I can ask?
Not a direct one. I have my mother's childhood friend has had Parkinson's for the last 10 plus years. She's actually a listener of this podcast, and she's a wonderful woman. My mum's childhood friend, and my mum's still very, very close to her. But that wasn't really the motivation for pursuing Parkinson's. As I say, a lot of serendipity, a lot of good fortune along the way. But my path was kind of set from about 20 years ago.
Well, we're glad to have you on our side.
You say Parkinson's. It's not just one type of Parkinson's. There's a whole range of different types.
Yes. I mean, this comes up very commonly in clinics. I still see a lot of patients in clinic. I do 2 or 3 clinics a week, and this comes up pretty much, every other consultation. What type of Parkinson's do I have? What is Parkinson's? What causes Parkinson's? And what I say to people is, Parkinson's is really an umbrella term for a collection of symptoms and signs that look similar in some ways. But within that, there are lots of different types, lots of different flavors of Parkinson's, and seeing someone at a single time point at the beginning, at that time, you really don't know which way things are going to go. So I always say to people, it's important to stay under follow-up with a specialist, with someone who knows you and your Parkinson's, to see how things evolve and manage things in that way, because there are lots of different possibilities, very broad spectrum.
You're now referring to the spectrum that is the isms or the plus variants of Parkinson's, are you?
Well, so when you see someone in clinic who tells you a story that fits with Parkinson's, and the examination is consistent with Parkinson's, the first thing you're doing as a neurologist is trying to work out whether there's Parkinsonism or Parkinsonian signs. And then once you've positively identified that, your role is to try and work out what's the underlying cause. And in most people, the underlying cause will be Parkinson's disease. I'll come back to that. And in other people, there may be another explanation, either another neurological disease that mimics Parkinson's disease, or another thing like vascular disease or certain medication exposures or things like that. Now, coming back to Parkinson's disease, I believe that although we're calling Parkinson's disease right now, over time, we will end up subtyping Parkinson's disease much further based on genetics, based on clinical features, potentially based on biological signatures in blood or in spinal fluid or on imaging. So I think we currently call Parkinsonism this broad thing. Within that, there's another very broad entity called Parkinson's disease. And I think over time, and if we want to find cures, we'll have to split Parkinson's more finely to make progress.
So Parkinson's is the son or the daughter, the child of the Parkinsonism.
Yeah, let's say that.
Let's say that, yeah, just for simplicity's sake. And we suspect that Parkinson's disease itself is going to bear a number of children itself, right?
Absolutely.
And that's what we're primarily here to discuss. Can I just start with the smell thing? Because
yes.
Because you raised it, it's an area of interest for you. I'm curious, Dave, you've lost your sense of smell, haven't you, Dave?
Yeah. It's almost completely gone, yeah.
It's almost completely gone, right?
Yeah.
I've still got my sense of smell. I don't know if it's deteriorating or not. And I know a lot of people are like Dave who've lost their sense of smell early on, particularly. Now, I'm in my second decade with Parkinson's and I can still smell. What does that tell me about my Parkinson's, and what does it tell us about Dave's Parkinson's, if anything?
I've got a couple of questions for you, if that's okay, before I answer.
Sure.
So first of all,
I feel like I'm in the in clinic now.
Yeah, the old switch. So, what age were you when you were diagnosed with Parkinson's?
38.
38. Okay.
Dave was 44.
Yeah.
Dave was 44. And how long you've had Parkinson's for? How long, Kuna?
13 years.
13 years. And Dave?
15 years.
So 38 and 44. And then the second thing to say is, have either of you kind of tested your sense of smell, kind of formally with a smell test?
No, I haven't.
First thing to say is that people's subjective perception of their sense of smell doesn't correlate particularly well with how they perform on objective tests.
I see.
So that means there are lots of people who think they have a good sense of smell, but maybe don't have a good sense of smell. And equally, there are people who think they have a poor sense of smell, but actually do pretty well on objective smell tests. So the first thing I would recommend, and this blows my mind because it's so important, I think, in the diagnostic process for Parkinson's and differentiating Parkinson's disease from Parkinsonism.
Everything else, other conditions, you could lose your sense of smell as well, couldn't you?
But it should be routinely tested in clinics.
So
and the
why,
nice guidelines,
why didn't my GP
Yeah.
13 years ago just give me a smell test? Wouldn't that have been one?
It's bonkers to me because it's such a cheap, simple test. And the nice guidelines say that, which is how we should diagnose and treat Parkinson's, tell us that we shouldn't use smell testing. But it's so it has so much potential value. So that's the first thing to say. The second thing to say is, my career in Parkinson's started with smell testing. I would say that smell testing right now, 22 years later, is of central focus in my career. So we were doing it all the way through, but now the focus is really on this. And one of the reasons is not only do we think it's a very good way of differentiating Parkinson's disease from Parkinsonisms, but I don't know if you've talked on this podcast about biomarkers for Parkinson's. There's this synuclein seeding assay, which can detect abnormal protein synuclein in the spinal fluid and potentially in other compartments like the skin or blood.
This is the breakthrough that came out last year from Michael J. Fox? Is
exactly.
That yeah,
yes.
Right. Okay.
And what's really interesting is because lots of people don't want to have a lumbar puncture and have their spinal fluid
examined. It's quite painful and daunting, basically.
There seems to be a very tight correlation between smell loss and a positive result on the SAA spinal fluid test. So it seems that smell testing indexes that change in the spinal fluid. And then the third thing on the topic of smell is the likelihood of your smell being abnormal and the likelihood of that SAA biomarker test being positive seems to be tightly associated with age. So if you have an earlier onset Parkinson's, you may be less likely to have lost your sense of smell, less likely to be that SAA biomarker positive. Whereas if you have an older age onset or longer disease course, you're likely to have lost your sense of smell and be positive. So there's something about aging as well in all this.
So the younger you are when you're diagnosed, the
more likely your smell is to be normal.
Right. Okay. But does it go on then to have a determining factor as to what prognosis looks like? Does it have a correlation to things like cognitive decline or anything like that? Difficult
to say. So we know that if you cross-sectionally take lots of people with Parkinson's, at the point of diagnosis, about 70% will have a poor sense of smell. And during the disease course, during their lifetime, about 90% will have lost their sense of smell. It's not clear whether smell loss indicates a more severe prognosis. And then again, most people have lost their sense of smell. But in people that don't have Parkinson's, smell loss is associated with cognitive impairment. So within Parkinson's doesn't seem to be the case, but in the healthy adult population, there does seem to be an association between smell loss and some cognitive impairment.
That's a bit of a relief for me.
Yeah.
Yeah, every time we have one of these conversations, Dave, I could see you holding your breath. He's like,
yeah, exactly.
Oh, no, does that mean me? Yeah. Well, Dave, there's no guarantee with any of this stuff, right, Alistair?
No, there's no guarantee with any of this stuff. And the most important thing, Dave, is that most people with Parkinson's have lost their sense of smell. Oh. That's pretty normal. For people,
so you're saying I'm the one that should be worried, basically.
But you were younger, so I think that's probably why your smell appears better.
I see. Interesting. I've heard talk of gut first versus nose first. Is that what we're referring to? When we talk about nose first Parkinson's, we're talking about those that have lost their sense of smell, the 70% that goes on to be the 90%, and then the rest are gut first. And if so, what's the implication of that?
Well, I don't think we know. I mean, this idea of brain first, body first is a concept that really came out of the team in Aarhus in Denmark, led by Per Borghammer. And I think, there's some preliminary evidence to support that Parkinson's may begin in the gut in some people and begin in the brain in other people, but it's not proven. Okay. But to your point, if you believe that the onset of Parkinson's can be in the gut, or something can get in from the outside, like an infectious agent, then the way that it would get to the brain early is via the nose or something like that.
Yeah. Now, infectious agent, you mean something like a bad virus, bacteria, or a parasite or something like that, right?
Probably not a parasite, but it is possible. There's no evidence to say that this is the case, but it's possible that some sort of infectious agent initiates the process. And our group has shown some associations with viral hepatitis B and C in the past. Other groups have shown associations, but not proven associations with influenza. And there are instances in the last 100 years of apparent outbreaks of Parkinson's within small communities. So one example is the Pacific island of Guam, where there was an outbreak of Parkinson's disease and dementia and motor neuron disease that occurred in an isolated.
Was this the pink one?
No, that was a different thing. So that was a genetic cause, but the Guam cases, essentially they never found an infection, but the assumption is that they had some sort of infectious or transmissible form of Parkinson's. So this is something that we're studying. We want to study on a very large scale whether exposure to previous infectious diseases might have predisposed people to Parkinson's.
There's some link with well water, isn't there?
Yeah, and I think the well water link is really a proxy for rural living and agricultural occupations and exposure to
things like GC that you mentioned before.
Yeah, or pesticides or things like that. Yeah. So, and we don't have many wells in the UK, but in other parts of the world, this association stands up pretty well.
What's your view on the paraquat scandal, if I can put it like that?
I think so. I think it's.
If you saw the news last week, they've now announced that they're going to stop manufacturing in the UK, right?
Yeah, so exactly. So I think this is really important. I think of all the pesticides, and there are many, many pesticides, the evidence base for paraquat linked to Parkinson's is stronger than the others. And we published on this about 15 months ago. And I think the correct policy decision is for the company to stop making paraquat and people to stop using paraquat. The more concerning thing about that whole story was the suppression of data by the company that was exposed in a Guardian
big bad
article.
Corporate.
Yeah.
Wow.
Yeah. So that was an amazing
piece of Hollywood movie starring Julia Roberts coming on.
Yeah, exactly. So it's an amazing piece of investigative journalism, really showed that they'd suppressed and also had sponsored academics to publish papers saying there was no evidence.
Contrary? Oh, yeah. that is scandalous. I didn't know that.
Yeah.
Okay, so there's a proven link. Good news that they stopped manufacturing it. Days from that part of the world, and we know quite a few parkies from that part of the world where they manufacture. The manufacturing plant in Yorkshire existed. So it sounds like the story's going to run and run once we can get to the actual truth. Can I just circle back and take a step back? And I'm just going to ask for a few yes or no answers. And I know...
Okay, quick fire.
You're not going to like...
I'm not going to like it.
Only because I'm trying to simplify here for us and our listeners. The younger you are, the slower disease progression is. Yes or no?
Yes, on average. Yes,
that
on
was
average.
Just the first question.
Yes, on average.
Yes, on average. Yeah. All right. The younger you are when you're diagnosed, the less likely you are to develop cognitive issues or dementia.
Yes, on average.
On average. All right, here we go.
Do well, Echo. Well done.
I can see the pain in your face, Alistair. It's very difficult to judge. I'm laughing here, but I do understand why you are hesitating because it is very, very difficult to pass comment in general terms, right? As we used as an example, we were just talking about Dave and I as in our patient profile. It's very, very difficult to do that. But having said that, I'm just going to ask you a couple more questions.
Sure.
The younger you are, the more likely you are to develop complications from having the disease for that much longer, and particularly taking the main gold standard drug for that much longer, levodopa. I'm thinking particularly complications like dystonia in certain instances, dyskinesia, and motor fluctuations, and the on-off periods that both Dave and I suffer from, having now been a more advanced stage.
Yeah, I think, dystonia is often a presenting feature of young onset Parkinson's. But yes, if you have to have, you're going to have a long duration of time with Parkinson's, it's more likely in that time you develop motor fluctuations and wearing off and things like that. The thing I would say is that, I'm a movement disorders neurologist, and the commonest movement disorder I treat is Parkinson's. But of course, as I'm sure has been covered on this podcast before, there's a lot more to Parkinson's than movement. Young or old, there's a lot more to Parkinson's than movement. And I think we focus understandably on the risks of cognitive impairment and, later stage things like dementia. But there is an appreciable burden of other neuropsychiatric symptoms like anxiety, depression, impulsivity, and in some people kind of risky decision making and behavior. And so back to your question about cognitive impairment in people with early onset Parkinson's, yes, it's less likely to have cognitive impairment in early onset Parkinson's, but I see quite a lot of other neuropsychiatric symptoms like anxiety, depression, and particularly things like impulsivity and things like that with dopaminergic drugs. And these are just as troubling and challenging.
You're right. We've done dedicated episodes on this, including a recent one about impulse control disorders off the back of a BBC
some frightening
investigation.
stories there.
Some really frightening, some very sad stories as well. So you are right to caveat in that way. When I said cognitive decline, I was really meaning dementia, and I think you've answered that. I've got to say that I'm pretty sure that both Dave and I suffer from mild cognitive impairment. Our ability to do this sort of thing has diminished. Even just having a conversation, remembering our words, organising ourselves, multitasking, admin stuff has become a lot more difficult. I still take comfort that doesn't necessarily mean that's going to go on and lead to dementia. We've had Professor Ramona Weil on the podcast before, and she's spoken beautifully about this, but it's probably worth reiterating. Just because I have that cognitive impairment doesn't mean I'm going to go on to suffer from dementia, does it?
No, exactly. And some mild change in cognitive processes from what you had previously, I think, is to be expected.
Right.
But it doesn't necessarily mean that will progress to the point where people have difficulty doing their activities of daily living, which is how we define dementia, when you can no longer perform the normal functions of daily life. So no, it's not. It's not. You should not think that.
If you're really stiff or move a lot, is that a different subtype of Parkinson's? Like Muhammad Ali and Michael J. Fox, for example?
Yeah. Well, Michael J. Fox in particular has younger onset Parkinson's, which is why he's had Parkinson's for a very long time. I mean, broadly, the split we make is in a kind of more stiff and rigid form of Parkinson's without tremor versus a subtype of Parkinson's with tremor. And in general terms, again, it's always in general terms, there are people who have tremor as the main manifestation of their Parkinson's, and that seems to be the main thing they have for years and years and years. And they don't develop a lot of the other features of Parkinson's, whereas on average, people with an absence of tremor and quite a symmetric, slow and stiff form of Parkinson's do seem to be at higher risk of having things like falls and potentially also mild cognitive impairment and things like that, and some more of the non-motor symptoms.
So you're drawing a distinction here between tremor-dominant Parkinson's and I'm testing myself here, PIGD. GD, yes. And I've been told I might meet the threshold for tremor-dominant Parkinson's. I think it's a calculation, I presume, off UPDRS scale, right? And you're saying that, sorry, let me ask this a different way. If you have a tremor, does that necessarily mean you're tremor-dominant?
No. So I actually, the way I write my letters, so if people are listening and come see me, the way I write my letters is kind of Parkinson's disease, and then I list out what the kind of main features are. But if someone has tremor-dominant Parkinson's, I'll put Parkinson's disease hyphen tremor-dominant, and then any other. I don't
that
write...
is a better form of Parkinson's, is what you're saying, in terms of prognosis.
On average, seems that people that have tremor as their predominant feature don't seem to aggregate a lot of the other symptoms that people with Parkinson's get. Now, that's not true for everyone, but as I said before, I have quite a handful of patients who have mainly one-sided tremor as their main manifestation. And other than that, they're doing pretty well. Now, I don't want to, although we think that tremor dominance is a good prognostic sign, I don't want to minimize that symptom actually, because for those people, although they don't have lots of the non-motor symptoms and things like that, potentially, that tremor can be really troublesome for what they're trying to do. And that tremor is also, I think, one of the more challenging things to treat with drugs. And, we try lots of different changes to medication to try and get control of that tremor. But ultimately, people may need a device-aided therapy like DBS or focused ultrasound. So it can be very troubling, that tremor.
Are tremor-dominant people more likely to develop dyskinesia as well, or other involuntary types of movement? Or is that not the case?
I don't know if they're more likely to develop dyskinesia.
Right.
But it's certainly possible for both of those broad subtypes of Parkinson's, if you like, to develop motor fluctuations and dyskinesia.
Okay. What about genetic forms of Parkinson's? How does that compare to, I think the opposite, you call it idiopathic, which I always think is a fancy way of saying we just don't know.
We don't know, yeah.
And sporadic, which I think is the same thing, isn't it?
Same thing.
Yeah. So how do the two differ? If you've got a genetic form of Parkinson's, which is about 15% of the Parkinson's population, that's where there's a known genetic link, although there's plenty of cases that we know of where Parkinson's is in the family, but no known genetic link, which is what the category of Dave is in. But if you are in that 15%, how does your disease look like? How does it progress? Is it quicker than the non-genetic form?
No, I mean, and within the genetic forms, there are lots of different genes that can, where if you have a change in the gene or a mutation in the gene and it causes Parkinson's, there are lots of different genes where that can be the case. But this is not a straightforward answer. As you said, the percentage of people we think have a genetic contribution is about 10 to 15%. And that varies according to the population studied somewhat and the ethnicity or the ancestry of the people studied. Within that 10 to 15%, there are genes where if you have a mutation, that is sufficient to cause Parkinson's. And those are things like SNCA, the synuclein gene, Parkin, PINK1, DJ1, a new one called RAB32, so something like that. And then there are genes where we think they're more risk factors for Parkinson's, like LRRK2 and GBA. And scientists and doctors can't agree on whether rare LRRK2 mutations and rare GBA mutations are sufficient to cause Parkinson's or whether they're still risk factors. But there are definitely in both those genes changes that only function as risk factors. And that's important because in the UK, at least, we don't even test for GBA outside of a research setting. That's not part of the panel in the NHS, but we do test for the other genes. But genetic testing is not widely utilized. I think it's mainly done at specialist centers. And if you have a genetic test and if you're found to have one of these mutations in one of these genes, then that does give you some information about the likely prognosis. Like, for example, if you have a LRRK2 mutation, it's likely your Parkinson's will progress at a slower rate than someone without a LRRK2 mutation. If you have a PINK1 mutation, it's likely that you have an earlier onset Parkinson's, and it's likely that you'll have dystonia as some of that. And so there are these kind of nuances. GBA, as I say, we don't test that in the NHS. Other countries do. It's possible that GBA variants give you a kind of nastier form of Parkinson's with more non-motor symptoms and more cognitive symptoms and things like that. But it's not done routinely in the NHS, and it's a research
but
test.
It's worth touching on because some of the online DNA tests do test for it. And I know one particular case of a lady that we featured on this podcast previously. Her initial genetic testing from the NHS picked up LRRK2. She subsequently went on to get one of these online tests done and didn't realize she also has GBA as well.
Yeah.
And that was news to her because it wasn't picked up previously.
She's got both. She's got both mutations in both.
Yeah.
I mean, the interesting thing, again, it's hard to know, but in a research setting where people have both mutations in both genes, they seem to have a milder form of Parkinson's, more in keeping with LRRK2 than with GBA.
That's what she's been told, and that's some comfort to her. And we'll leave links to where you can get standard genetic testing if you haven't done so already in the show notes of this podcast. We always highlight PD Frontline, Alistair, as the default place to go, right?
Yeah.
I
would just, sorry, Kieran, I would just like to say, I mean, on that note, you gave me a useful prompt there. So one of the other things that makes genetic testing important, either in a clinical setting or research setting, is there are drug trials for the various genetic subtypes of Parkinson's, where if you are positive for a mutation, your likelihood of being eligible for those trials increases significantly. And so PD Frontline is a good place to go for research grade genetic testing and clinical trial opportunities.
Does exclude you from other trials though, doesn't it?
Potentially, yeah. So it's,
well, there's stuff going on in the genetic space. Let's say, let's take some comfort from
absolutely,
from that.
And not just PD Frontline. I mean, I spend a lot of my time, which I've not mentioned so far, working on this project called the Global Parkinson's Genetics Program, which is this enormous initiative around the world trying to understand the genetics of Parkinson's. And this is
this the PG? What's the abbreviation for it?
Well, there's PD gene.
Yeah, PD gene, right?
Which is in North America and Latin America. And that's supported by the Parkinson's Foundation and GP2, which is the Global Parkinson's Genetics Program. But PD gene and Frontline are a great example of kind of initiatives that are supported by GP2 to provide genetic testing and identify people that will be eligible for clinical trials. And I think in the future, when we have, disease modifying drugs, we will be trying to classify people according to the genetic contribution and using targeted drugs on particular genetic pathways that have gone wrong. So I think this is the future.
This is the future, but for the here and now, all these things we're discussing, genetic forms, non-genetic, late onset, young onset, whether you've lost your smell or any of these things, why does it matter if we're all going to get the same sort of treatment regardless?
Well, that's a very good question. I hope people don't all get the same treatment, although I agree that a lot of people will, at the point where they have, impact on activities of daily living, will end up on a backbone of levodopa. But I do think accurately capturing the motor and non-motor problems and, where possible, genetic subtypes or other types of Parkinson's allows one to tailor the treatment appropriately and also, estimate prognosis and also when thinking about clinical trials, try and decide on which people are right for which trials and things like that. So I think it is important right now. I'm sure you've heard this expression that everyone's Parkinson's is different. No two people are the same. And that's why it is important to kind of tease apart what the main issues are for that individual and how you can help.
How many different genes are linked to Parkinson's at the moment? What's the number?
It's not an easy answer, Dave, because there are about 10 mostly rare or very rare genes that are sufficient to cause Parkinson's. But it's likely that most people's Parkinson's has a genetic influence. Even if it doesn't have a genetic cause, a single genetic cause, the flavor or subtype of Parkinson's that people have likely has a genetic influence. Small variations across the genome that increase the likelihood of something or decrease the likelihood of something else. And so when people say, is my Parkinson's genetic? I say, well, it's complicated. I don't think there will be a single genetic explanation for your Parkinson's, but your genes definitely influence your risk of Parkinson's and how it manifests over your life.
And all of this is different to being hereditary, isn't it? You can't directly equate one with the other,
exactly.
Can you?
Exactly.
Yeah. I mean, to be honest, that's the first thing that people want to know, right? Are my kids going to get it?
Yeah.
And I say probably not. Whatever the cause, more likely not than yes. In the very rare instance that people carry, an SNCA mutation, and that's dominantly inherited, there's a high likelihood of children getting this, but very rare scenario. Even if you have a LRRK2 mutation and you pass that on, it seems that even if that child carries the LRRK2 mutation, there's only about 20% chance they'll ever see Parkinsonism in their lifetime. So getting the mutation doesn't necessarily mean you'll get symptoms at some point when it comes to LRRK2.
That's a big fear for parents, isn't it, who are diagnosed? They're worried, my kid's going to get Parkinson's,
I always say probably not.
Did you ask that question, Dave, when you first got diagnosed? You must have done.
I was diagnosed when I was 44. My dad was 44 as well. And my genome's been sequenced. I haven't got any genes that are linked to Parkinson's. But, it does worry me. I've got 2 boys and, I think, what's going to happen to them,
Yeah. Alistair, I'm just going to change tack here a little bit. I heard, and pardon the pun, but I heard that hearing loss might be a thing in Parkinson's. When I say I heard it from you in one of your papers or one of your research findings. Is that true?
I think it is a thing. I don't think it's as big a thing as smell loss in Parkinson's. And you had Ramona Weil on as well. I mean, Ramona's been focused on vision in Parkinson's. I think when it comes to our special senses, vision, hearing, smell, part of the problem there is the way that those external inputs from the special sense organs are interpreted and responded to within the brain in Parkinson's, and the role that the central brain structures have in interpreting those signals. So I don't know whether you really lose your hearing or your ability to decode what you're hearing is impaired.
But to the patient, it's the same difference, isn't it?
Yeah, to the individual with Parkinson's, it's the same thing. And where you see this is in circumstances where there's conflicting stimuli.
Visual sensations as well as auditory.
But also competing noise. So in a consultation, people do pretty well. Round the dinner table, they don't do well.
Well, that's the situation I struggle. I struggle. Like, the TV's on here. Helen's like cooking over there. The washing machine's back there on. And for me, not only can I not compute it all, it actually just gives me a headache.
Yeah.
So, and I'm pretty sure I've been in the pub with you, Dave, a few times when it's got a bit noisy. I'm pretty sure your hearing is impacted somewhat, but you're pushing 60. It might be an age thing as well, right? So, I just want to be polite, but I think your hearing and probably mine is suffering a little bit, but I can't be certain about.
I find when I'm walking, I find it difficult to have a conversation with my wife because I'm concentrating on putting one foot in front of the other and not concentrating on what she's saying, and she might think my hearing's going, but it's not. I'm just concentrating on walking.
Well, we call that dual tasking, and so in a research setting, where we're looking at prodromal Parkinson's and people we think may get Parkinson's in the future, one of the ways that we try to bring out some motor signs is by getting them to concentrate on something else. And we do this in the clinic as well, actually.
Yeah, somebody's observed in my tremor. They asked me to pat down.
I get people to do a cognitive task if they've got no tremor at rest, and doing the cognitive task brings out the tremor. And just back to your point,
take away 7 from 100.
Exactly. Or I do. Well, I won't tell you what I do. Otherwise, people will practice before they come to see me.
That's true. Just on that note, why do you always use the same 5 words? Church, what was it?
Apple.
Church, apple, daisy, red, something like that.
That's right. There's one more.
It's part of the mocker. Actually, they've changed it now. There's a new version of it, so that's tripping people up. I do have someone I see who every time he walks into the room, he says, "I've been practicing that test." So of course, before he comes to see me, he scores the same on the test because he's practicing the test before he comes.
Don't cheat. It's in no one's interest to cheat, right? Be honest. And anyone going for a cognitive assessment as part of any kind of advanced therapy, just don't cheat. There's no. It's not a test in that sense, is it?
No. They do more detailed. No, for DBS, as you know, Kuhan, they do more. They do more than just that kind of screening test.
The cognitive testing for DBS. Oh my God, that was so intense. Yeah. I mean, I don't think I was meant to be off medication that day, but I was going off so rapidly because my brain was so engaged with these tasks, not just arithmetic, but you get visual cards, you've got to remember them, you've got to say words back after a few minutes that you've been told to memorize and things like this. And it was
like
for
boot
about
camp.
Yeah, exactly. It's like 2-3 hours of it. I was by the end of it, I was like, but that's the thing, isn't it? Because not every day is the same. Now I have DBS as well. I can feel that a little bit more, that every day, actually, the level of stimulation, the level of dopamine that I require is fluctuating according to what I'm doing on that day. If I'm sat at home on a Sunday watching telly all day, actually, I can tone down the medication or tone down the stimulation. But if I'm doing this sort of thing, talking to you, going to another meeting after this and having another call later and so on, particularly if I'm engaging brain or editing a podcast, I go off so quickly.
Really?
Yeah.
It's interesting.
I mean, I think one of my bugbears is that when we as patients present in clinic, you're only getting that snapshot view, right? And for example, Dave often has his appointments in the morning, and he's best at the morning. Whereas, afternoon, he might be playing tennis, we might have done a podcast. You see him after, he'll be a complete different person, right?
Slow
It's
right
not
down,
a
yeah.
uniform thing. Sorry, I'm going all over the place
No,
here.
you're good.
Can I ask about the part of London that you're in, Alistair?
Yeah.
And the patients that you see. Let's talk about your patients firstly, because you said you were practicing 2-3 days a week. How many patients do you have on your books, if you don't mind?
Well, I do an NHS clinic on a Tuesday afternoon. I do a private clinic as well once a week. So in my NHS clinic, that's based in the Royal London in Whitechapel, I think we have about, on my books, have about 400 or 500 people, but within the trust, we have about 1,000 people with Parkinson's or Parkinsonism. So it's large numbers.
How many people do you think you've diagnosed with Parkinson's, Alastair?
I don't know. Well over 1,000.
Wow. Are you struck all the time about how different we each are, right?
Yeah, absolutely. I mean, the interesting and satisfying thing about Parkinson's is dealing with the patients, is meeting the patients, because it's a very nice patient group to work with, and it is a very challenging diagnosis that you're always learning on both sides, and will always challenge you with new things that you have to work out and sort out. So it's satisfying that way. The bit that's not satisfying is right now we don't have things that we would call cures, but I'm hopeful in my career that will change. I'm really excited about the trials that come through. I mean, going back to East London, it's a really interesting place to work. We have a very diverse and generally, not exclusively, but generally deprived population with a lot of other health problems and social challenges. And so the Parkinson's that you see in East London is a challenge compared to, other places I've worked. I would say about a third of people maybe a third or a quarter don't have English as a first language. So again, so much of Parkinson's
Bengali
management,
population, right? South Asian,
but also East Asian, African, Latin American, and Eastern European.
And have you seen enough or researched enough to know what the differences are in patterns of Parkinson's amongst each group?
Yeah, we've got a really important project on this called the East London Parkinson's Disease Project, imaginatively named. So first of all, we think that probably things like cognitive impairment and non-motor symptoms probably are a little bit more common in people of South Asian descent and black patients. But we also recognise that the tools we use to pick up cognitive impairment and non-motor symptoms are not fair in certain kind of ethnic groups.
Because of language or education or...
But both education, language, but even when you take account of language, perhaps something
perceptions?
Around the familiarity of the task, pen and paper tasks, a lot of these tasks on the mocker, for example, are like little games that we grow up playing.
So we have that muscle memory, but
exactly,
it's a new environment, right? It's a new right. I see, fascinating. So you talked about non-motor. What about motor? I also read that South Asian and black people are more likely to are going to have more severe motor symptoms. Is that right?
Yeah, potentially, and this has always been put down in the literature to potentially more in the way of vascular, co-pathology, additional vascular burden in the brain. But I'm not sure that is true, actually. We don't see a lot of vascular disease on the brain scans that we do. So it seems that there is a potential for a more severe manifestation of Parkinson's. And we've studied a little bit whether that could be due to type 2 diabetes and the higher rates. I'm not sure that is, and we're trying to understand more about that. So just explain,
if you have type 2 diabetes, you're more likely, 30% more likely to develop Parkinson's. Is that right?
That's what our research shows.
Yeah, right. And what about dyskinesia? I read somewhere that people from a South Asian background are more likely to get complications like dyskinesia. I'm saying that because before my surgery last year, my implants, I was having a lot of dyskinesia, and anecdotally, and it's only anecdotally, a lot of people from the South Asia community I see with this condition are suffering with dyskinesia. Is that something you've seen
Yeah,
in evidence or?
Yeah, I see it a lot. But it may be greater susceptibility to dyskinesia, or it may be in people that don't have English as first language, not you, Kuhan, but other people who don't have English as first language, that the way that the consultation goes makes clinicians prescribe more levodopa, and that in turn leads to higher rates of dyskinesia. So it's hard to know if it's susceptibility to dyskinesia or different prescribing habits as well.
Just out of interest, when you have a patient that you see in clinic that where English is not their first language, or let's say they don't speak any English at all, what do? Do you have a translator there, or how does that work?
We have been very fortunate until very recently. We had funding from Parkinson's UK to fund a coordinator in our clinic for the last few years who was Bengali speaking, and Bengali is really the second main language. And so she's just been wonderful. She's been an ever present in our clinic, supporting the consultations and doing lots of research as well. It's been multifaceted help from the coordinator, but we don't have that funding anymore. So we're trying to secure further funding. It's so important to have that person in the clinic with us. Some of our team speak, we've got Arabic speaking, Romanian speaking, Bengali speaking members of the team. Our team is very diverse as well. But we'd like to communicate in people's native language if we can.
In a minute, I'll test out your Tamil and see how you are.
I'm terrible. I know a couple of things. I know mamblam.
Mamblam. Mamblam is it's a food, right?
It's mango.
Mango.
Yeah.
Yeah, mamblam. Of course I know mamblam. Oh my. You don't know how impressed my mother is going to be when she listens to this. That Professor Alistair Noyce is talking about mamblams. Honestly. Very good. Very good. Sorry, was not expecting that at all. You completely throw me. I did have a follow-up question, but I'll hand over to Dave while I think of that follow-up question.
We're nearing the end because, we've had nearly an hour of your time, which we were very grateful for. But I just wondered if you got some words of optimism for people with Parkinson's about the future. You deal with the cutting edge of research and, all the top people in the field. What optimistic message would you leave us with?
I'm going to caveat it before I give you the optimistic message, which is I've also been told not to be too optimistic by people with Parkinson's. They say,
can I just tell you, Alastair, you're not going to win. Either way, you're not going to win.
Yeah.
No. Right? You're going to piss somebody off.
Yeah, well, that's true. So I'm not...
Just tell us what you think.
I think there has never been a more exciting time to be involved with Parkinson's disease from a clinical research perspective. We are on the cusp of biomarkers for diagnosis, biomarkers that will predict the type of Parkinson's you have and its progression. And those are the key things that you need to enroll the right people in clinical trials to show disease-modifying effects. So I think over the next few years, we are going to see positive trials for Parkinson's in the same way we have suggestive signals from Alzheimer's disease and other neurological disorders. And I think it's a really exciting time. It still takes a long time to get those treatments into the clinic, but I think this is, in history, this is the fastest moving time of Parkinson's research that there has ever been. And I think it's very, very exciting.
What can we do to help?
What you can do is use your platform, your Two Parkies in a Pod platform, to encourage people to take part in clinical trials. And, obviously, the clinical trials are experiments. There's lots of things to consider. But the way that we will end up with disease-modifying therapies and cures is if people are willing to take part in those clinical trials. There's lots going on right now for genetic subtypes, but EJS ACT-PD, which Frontline is recruiting to, these are really important things. But we need numbers. We need people. So
absolutely.
That's what you should say.
Been under representation from certain ethnicities. And more generally, I think I read somewhere that less than 1% of people take part in clinical trials for Parkinson's. So, the more we can get, the better, right? And the more diverse we can get, the better. We have taken a lot of your time. It's been great. I feel like we've only just scratched the surface with this. Maybe we'll have you on again in the future, Alastair, if you don't mind.
That'd be a pleasure.
It's been a really fascinating chat.
Yeah.
For the time being, thanks very much for joining us today.
Thank you. I think you're both doing a remarkable job with this podcast, and it was an absolute pleasure to be invited and very happy to come back in the future.
The wonderful Professor Alistair Noyce there. He makes complicated things seem very simple, doesn't he? He explains things brilliantly.
He does, yeah. It is quite complicated discussion to follow then. We were going off at tangents, probably our fault a little bit because we were pulling him in different directions. So
you want to pick that magic brain, don't you? That's the thing. You want to get all the information you can out of him.
Yeah, exactly. A little bit frustrating. We couldn't get yes/no answers, but that's just the nature of Parkinson's. I was trying to put him on the spot with those quick fire questions.
Wasn't having that, was he? He wasn't having that.
Well, it's just there's no easy answers in Parkinson's, basically. But he explained it as best as possible, and I've certainly come away more in line. I want to do a smell test. I'm going to order some smell tests for us, Dave, because I think that might be quite revealing.
We'll do that on air.
We'll do that on air. Yeah, scratch and sniff.
Yeah.
Sounds a bit rude, but yeah.
I'm not scratching and sniffing you. After a game of tennis, we'll do scratch and sniff. Horrible.
Please. Scratch me, Dave.
Where do you want to scratch you? Give me armpits.
No, let's be serious.
Yeah.
I think it did also highlight the genetic forms. There's so many different types, right? Which I didn't really appreciate. I don't think any other neurologist in the world would see such a diverse population in his clinic, right?
It's a very, very ethnically rich part of the country, isn't it? East London, where he works. Incredible people. People are there from every corner of the world.
They are. And that's got to be very enlightening for him, right? I'm sure he's... I mean, you could tell he's a sort of consultant that would be listening to his patients and taking stuff on board and feeding it into his research. And that sort of stuff is valuable. And research, really... I'm still amazed at how few people get involved in research. And he mentioned a few. We'll leave
1%.
Yeah, less than 1% of people get involved in Parkinson's research, clinical trials anyway. And we have highlighted ones before. PD Frontline is the one that's out at UCL that will give you genetic testing. So if you want to know if you have genetic type of Parkinson's or what type of Parkinson's, you can do that. It's all free, by the way. I think it's a saliva test that through the post. And EJS ACT-PD is the clinical trials that we referenced there and we highlighted in a previous episode as well. That's the kind of fast-track clinical trial process that's just been set up. I've been a patient representative on that program for the last 2 or 3 years. There are 3 candidate drugs that are being trialed at the moment. There's more drugs coming along. They're all quite promising. And they're all quite later on in the stage of clinical trials and that they're safe to use. And I'd recommend anybody to sign up for that stuff if you meet the right criteria.
Real hope, those, aren't they? Giving us real hope.
Giving us real. We can't get there without that kind of involvement, unfortunately.
No.
So if you want to do something off the back of this podcast, listen to podcasts like this, listen to episodes like this, just get involved. Honestly, don't fear. You'll get really well treated as a result of it because I was talking to Rory Kethlin-Jones the other day, who signed up for EJS ACT-PD as well. And he says it's great because he doesn't know whether he's taking the real drug or not, one of the real drugs or not, but he's getting a call from his doctor every week asking how things are going. And that level of care is what you get when you get involved in research, right? You get that follow-up. So if for no other reason, to get a better quality of care, if your professor invites you to go on to a research trial, just say yes. Just say yes. Don't hesitate.
It gives you access to the brightest brains of the Parkinson's world. Why wouldn't you? For free, you know?
Exactly. And I know it's not directly comparable. I know COVID was not neurological conditions, but the only way we got to a vaccine then, in that case, in less than a year, because hundreds of thousands of people came forward to take part in clinical trials. And there was this huge momentum for what was an epidemic. And as we're hearing from in the Parkinson's world, the numbers just, I don't know what the definition of an epidemic is, but numbers will double in the next 25 years, right? So let's take some action here, people. Come on.
Get on board as soon as you can. Enroll for some research.
Exactly. And in the meantime, Dave, do we have any people doing amazing things by any chance?
It's funny you should mention that because we do have some amazing people doing amazing things.
People with Parkinson's do amazing things.
Michael J. Fox reacted with great humour after a tribute video sparked fears he died. How do you react when you turn on TV and CNN's reporting your death, he said? Do you A, switch on MSNBC or whatever they call themselves these days? B, pour scalding water on your lap and see if it hurts. If it does, you're fine. C, call your wife. Hopefully she's concerned but reassuring. D, relax to do this once every year. E, ask yourself, what the... I thought the world was ending, said Mike. Apparently it's just me. I'm okay. Love Mike. Brilliant. Great reaction. Great bit of humour.
What idiot at CNN did that, right?
I know.
They should be fired.
They do these obit tapes before people die, don't they? And one of them's gone out by accident.
People with Parkinson's do amazing things.
Legendary Parkie John McPhee has written a book. John walked the length of the UK from south to north in a straight line. The Long Straight Walk features John and the characters he met along the way. It's available now on Amazon. A link is in the show notes.
Wonderful. Well done, John. I think he took part recently in a Cure Parkinson's video as part of Awareness Month in April. So I think I'm right in saying that. If I am, I might include a little clip right now.
My name's John McPhee and I was diagnosed with Parkinson's disease in 2012. Symptoms for me was I had dystonia in my right leg and also my right hand shook quite forcibly. I could be quite active one moment and almost completely immobilised the next. In a roller coaster ride, it really has. I had to retire with some of the symptoms that I had from Parkinson's, or falling asleep and also stress. At no time before my diagnosis had I ever considered being disabled. The everyday challenges you face with Parkinson's disease are varied and many. At times when my balance isn't quite as good as it could be. In fact, just 2 weeks ago I fell through a wall walking backwards. Getting my socks on. I know everybody says it's easy to put socks on, it's not. All the different challenges that you've got, whether it be your balance or your sleep, affect yourself and it can affect the rest of the family. Your Parkinson's mean a heck of a lot to me. It's great to have somebody knowing that their focus is on making you better. A cure. It gives me hope that looking into the future, there would be some time when I'm going to be able to take control of my own life and hopefully not be in a wheelchair. Fundraising has been something I've done ever since I was diagnosed with Parkinson's. I've taken on various challenges, whether it be cycling around Iceland or walking the length of Britain. I got involved with fundraising because it's hugely important to me to be in control of what I can do for curing Parkinson's. If we can get more people from outside the Parkinson's community supporting Cure Parkinson's, we've got more chance of raising enough funds to get the next trial up and running. If you fundraise, you can fund research. If you fund research, we'll find a cure.
People with Parkinson's do amazing things.
Now, imagine a garden filled with beautifully scented flowers, but you're not able to smell any of them. This is the reality for many people living with Parkinson's. Parkinson's UK has launched a scentless flagship rose in a partnership with Harkness Roses. It's called Parkinson's Resilience. If you want to buy one, you can do. In the show notes.
What is it, a flower?
A smellless rose. It's a rose that they bred that doesn't smell. So you know what it's like when you got people with Parkinson's. They're going to sell it at the Chelsea Flower Show.
Oh, you mean to demonstrate to the public what living with Parkinson's... That's amazing.
Yeah, exactly.
I didn't know that.
Yeah, incredible.
What's the name of it?
It's called Parkinson's Resilience.
Oh, that's beautiful. So Chelsea Flower Show, hey Dave? Are we going to the Chelsea Flower Show?
I think we might be, yeah. Parkinson's UK have got a garden.
We've been invited,
I think some of these roses are going to be in the garden.
Great, and we're going to meet Ara Anderson there, the TV presenter. It's her sister, I think, with Parkinson's. So that's her motivation for getting involved in the Parkinson's garden at the Chelsea Flower Show. So we will report back.
Buy yourself a Parkinson's Resilience rose. £5 of every sale goes to Parkinson's UK.
Great.
People with Parkinson's do amazing things.
Here at Two Parks in a Pod, we love the attitude of Suk Heng Adams, a former nurse with Parkinson's who used to look after people with the condition. The positive attitude shines through. I live for now, do as much as I can, I do things I enjoy, I visited a place I've always wanted to visit, and generally live life to the fullest. Keep on doing it, Suk.
Well done, Suk. Well done.
Great attitude, great attitude.
People with Parkinson's do amazing things.
A rabbi from Leeds has raised more than £16,000 for Parkinson's UK.
A rabbi from Leeds? This is the start of a joke.
No. Albert Chait, MBE, known as Albie, has marked his 40th birthday with a challenge to complete 40 push-ups every day for 40 days. To honour his late father, his dad, Reverend Henry Mark Chait, was diagnosed with Parkinson's just before his own 40th birthday and lived with the condition for more than 30 years. Good man, good man.
Yay. I think he follows us as well. So I'll hopefully hear this message. Well done, Albert. I'm off to find some puffins now, Dave.
You
Any
struggle in
tips?
South West London.
I think so.
You don't see puffins going down Balham High Road.
No, you don't. You see a few sights though, don't you?
Yeah, exactly. Hopefully we'll find a puffin. I'm going searching again on Tuesday, so hopefully we'll find one. Good to talk to you, Kieran. I'll see you soon for a game of tennis.
See you next week.
See you, bye.
Yeah, cheers.
Love you,
See you,
bye.
bye.
You've been listening to Two Parkies in a Pod, a Parkinson's podcast with Dave and Kuan. To get in touch, visit the website twoparkiesinapod.com or send your voice notes or emails to hello@twoparkiesinapod.com.